So let's jump into the pregnant and postnatal population. Yep. So there's a few conditions that are relatively common, and so I just want to go through a couple of them and talk about what some of the common signs and symptoms that you would see. But let's start with de Quervain's, and I was thinking about this when I was writing my questions, and I was thinking, I don't know these days if it's called a syndrome or a disease or a Tenosynovitis. What's the terminology these days? Do you know?
Yeah, it's usually called de Quervain's Tenosynovitis. Mm-hmm. Strictly speaking, it's not a Tenosynovitis, it's a Tenovaginitis. Okay. But you don't ever see that being used. It's most commonly called de Quervain's Tenosynovitis.
So let's talk a little bit about the area that we're talking about, so the anatomy and what's happening with those.
Okay, well, if I can borrow your hand. There are three main tendons that help to pull your thumb back. So if you can give me a thumbs up there, you can even see these two, it looks like two bands of tendon. There's one that comes from the tip of the thumb and runs diagonally more towards the back of the wrist. That's your long extensor, thumb extensor, not associated with de Quervain's. Mm-hmm. Then you've got two short ones here. It looks like one tendon, but they're just two tiny little ones running together right across the most prominent piece of the radius here. And that's where de Quervain's happens, right there where those tendons cross the bone. So the pain is usually felt very specifically in that location, sometimes extending a little bit in a band up and down there, but it rarely causes pain spreading, radiating anywhere. It's usually very local, very specific. Those tendons come from little tiny muscles, baby dinky little muscles roughly underneath where a watch band would sit. And so they come obliquely across this way and then run down into the thumb, one to the base of the thumb and one to the tip. They're very small muscles, they're not power muscles. Yep. All they need to do is to help pull your thumb back if you're reaching out to grab something. Mm-hmm. But they cause a big problem in this situation, and particularly for new mums. New mums go from normal hand use to suddenly spending hours a day, day and night, holding a baby. Yep, that's right. Yeah. But absolutely. But it's the feeding, but it's also the if you are reaching out holding a baby, you can see the tension that is coming through that tendon, and then with that tension of the thumb, you're then moving your wrist. Yep. So putting the baby in and out of the car seat is usually excruciating for people with de Quervain's. Up and down off change mats, bathing, feeding, all of these things. It just throughout the day, there's so many movements like that. So what that does is it starts a cyclical problem. It usually begins very mild, and it might only be a couple of times a day. When you really push it hard, you get a tweak of pain in there. Mm-hmm. But then each time you do that, the injury results in inflammation around the tendons, and that inflammation results in thickening of the lining around the tendons, the synovial sheath. And that thickening kind of squashes in on the tendons and makes it tighter and jams it up a bit more, which makes it easier to re-injure it the next time. So then you have another injury episode and the cycle keeps going. Mm-hmm. By the time the patients come to see me, it's often been going on for sometimes 3 months, 5 months, 6 months, whatever. And they've gone through that cycle so many times that it's not just twice a day, but it might be 200 times a day. And it's not only when they really push it, but it's when they flick their hair back, or when they pull up their undies, or adjust the sheets at night, and every little thing. So
will it wake them up at night sometimes when it gets to that point?
It absolutely, yeah. In a severe case, an acutely inflamed case, it can be an excruciating, searing pain. It can really affect people's quality of life and their sleep. It can make people feel like they're going to drop their baby. It can be quite distressing.
So if you see people in those early days, so just say that it's happening that 2 or 3 times a day, and there's no night pain when you're not doing anything with it, it's not there. Yep. I'm assuming that's a lot easier to treat.
It makes a huge difference.
Yeah. So what would you do at that point if they came to see you?
The first thing I'm going to do is to assess the patient and make sure that we are treating de Quervain's. Yep. Okay, there are other possible causes of pain in that location, so I want to rule those out. Once I'm confident that it is de Quervain's that's going on, then my next step is always education. I need to make sure that the patient understands, in a bit more detail, that the same kind of stuff we've talked about, the anatomy in the area. I'll draw pictures of the way the tendons move through the sheaths, and then I'm going to talk about that inflammatory and thickening cycle, and that leads to a discussion about the different management options that we have. Mm-hmm. The thickening is kind of the key issue. We've got to get that thickened sheath around the tendons to go back to normal again. but I can't make that happen, and patient can't make that happen instantaneously. Surgery can be used in very, very extreme cases which don't respond to other therapy, but that's the only way we have of actually getting rid of that thickened tissue, and it can be avoided in almost every case.
Great.
So then you could look at, well, how can we treat the inflammatory part of the cycle? Can we settle that down so that then the thickening has a chance to resolve? But most people who are pregnant, or sorry, who have a baby, are breastfeeding, and so taking anti-inflammatory tablets is often not an option. Cortisone injections are sometimes used, and they can be a really helpful part of managing severe de Quervains. But there are reasons that you don't always want to use cortisone injections. So it then comes back to, can we break the cycle at the point of injury? Can we stop that ongoing aggravation? So making sure that the patient understands that every time they do a movement or an activity and they feel that pain, it's not just pain. A lot of people are very tough, particularly new mums. They're putting up with all sorts of stuff in their life, which is often very difficult and very inconvenient for them. And this is just another thing that they think they'd have to put up with, and it'll be okay, it'll get better, it'll sort itself out.
I'm tired.
Exactly. Yeah. There's heaps of other things to deal with. So, making sure that they get that point, that every time they get that pain, the cycle is going to continue and it's going to keep increasing and increasing. So we've got to break it there. If we can break it there for long enough, stop the ongoing pain, then the inflammation will naturally settle down. And slowly, eventually, over many weeks, the thickening will resolve. The compression, the tightness around the tendon will decrease, and it'll get less vulnerable to re-injury, and the cycle reverses.
Fantastic. Yeah. Now, we were going to talk a little bit about splinting. Did
Absolutely.
you want to have a little crack at this?
Yeah.
So, will you always splint people with Quervains?
No, a big part of my assessment is trying to classify, I guess, or rate the severity of the presentation. So that's going to depend on how easy it is for me to bring on their pain with various tests, and it's going to depend on how long it's been there and just how severely it's described. People who come in with very mild de Quervains sometimes don't need splinting. And sometimes it's enough just to explain the problem, to let them understand that they need to avoid that pain, that re-injury, and they can say, oh, great, no worries, I'll delegate that task to my husband, I'll break this task up into smaller pieces so it doesn't become a painful problem. I'll have extra rest breaks when I do this task, and I'll adjust the way that I feed my baby. Problem solved. But like I said, most of the people that we're seeing are not in that really early, really mild stage. Usually it's been going on for quite a long time. In that situation where it's more moderate to severe, it's very, very difficult to avoid ongoing pain episodes without some form of splinting. Some people...
So it's got to that very irritable stage.
Yeah, some people can get away with just a little bit of strapping tape or even kinesia tape or something like that, just as a reminder to modify their activities. But if it's not actually stopping your movement, you still have to be alert 24 hours a day almost, to what you're doing so that you don't keep hurting yourself. With a plastic splint on, it does the thinking for you. You can be confident that you're not going to keep hurting it whenever you're in the splint. All right. This is the kind of pattern that I use for a wrist and thumb splint. It's important to immobilise or support both the wrist and the thumb because it's the combined wrist and thumb movements that are the problem. As people get better, we can sometimes cut the splint back so that it is just immobilising the thumb and get the wrist free, or vice versa. Cut the thumb free and keep immobilising the wrist, depending on which is more of a problem. So this is a low temperature thermoplastic. As you've seen, it's fairly rigid at room temperature. When we drop it in the water, it becomes soft and mouldable. So while it heats up, I'm going to get you into the position we want for splinting, which is around about there. It's a baby holding position.
Functional position.
That's right.
And when they're wearing a splint, I'm assuming they take it off to gently move their wrist and thumb.
Yes. I'm usually going to start with people splinting almost full time. Taking it off for skin care, for washing and drying the arm, but wearing it almost full time so that you're not getting those incidental. Is that too hot for you? Yep. Usually pretty comfortable. You want to avoid even the little incidental moments where you're aggravating it. So we wrap this around you. There's definitely a place for gentle exercises to try to minimise stiffness and to maintain a little bit of tendon glide through that sheath. but they need to be done within the limits of pain.
Yep.
You can't allow your exercises to become yet another aggravating factor. So we just make sure that you're maintaining that good functional position, slight wrist extension, opposable thumb, and it hardens again as it cools.
So simple.
Yeah.
Well, after years and years of training, it looks really simple. It's very comfortable.
Good. It's really normal for people to feel that it's a bit uncomfortable when it first goes on. Well, not when it first goes on, but when they first try using it.
Yeah.
There's a general sense of restriction and awkwardness because its job is to limit your movement. If you can stick with that, work through that for a couple of days, then you literally learn to work around it. Your brain and your hand get used to it being there, and it stops being an obstruction, and it just becomes something that you work around and work with.
And presumably the pain reduces, which makes people more happy to wear the splint.
Yes, it does help with compliance, absolutely. But it's a lovely plastic because it's waterproof, so you can wear it swimming, snorkeling, scuba diving, and showering. Washing babies. But something like showering is often a pain aggravating activity. Drying yourself, washing your hair, those kinds of things. So we slide that off. So then it's just a case of trimming off the excess plastic and putting Velcro straps on to hold it in place.
And in terms of the, once people start to have treatment, obviously it's going to depend on the severity of the case, but are we talking that it takes weeks to months, presumably, for
typically
resolve?
There's going to be a shorter period of almost full-time splinting, like we've described. In someone with a mild case of de Quervain's, that might be only 2 weeks. In a severe case, it might be anywhere from 4 to 6 weeks. I'm very reluctant to keep people in a splint full-time or close to full-time for anything longer than that because it starts to cause its own problems. Joint stiffness and muscle weakness and dependency on the splint. So if someone is really not improving with splinting and gentle exercise after, say, 4 weeks, that's when I would definitely be considering a cortisone injection as an adjunct to what we're doing here. So there's your basic splint. The edges can be dipped and rolled back for comfort.
Yep.
Velcro straps across the gap there, which you can adjust for tension. And it's totally remoldable. So if it is causing pressure areas or discomfort on the skin, bring it back in, dip it, heat it, and fix it up.
One thing that I just ask, Ian, is comparing something that's custom made to, obviously there are products that people can get from a pharmacist or from a,
medical supplier or pharmacy.
How do they compare? Obviously,
there are lots of options on the market, none of which we stock because we've got the option of making custom made. Yeah. I guess my big concern with the off-the-shelf ones is that they are usually, there's fitting issues, of course, because they're usually one size fits all, or a small range of sizes is supposed to fit all people. So it's probably going to be slightly too big or slightly too small for you. It's either going to be too tight and uncomfortable, or it's going to be too big and sloppy. But they're also designed to be as comfortable as possible, and so they're padded to the nth degree, which means they're almost always not restrictive enough. Basically, if you put the splint on and it's still possible for you to move to the point where you get pain, it's not doing what you needed to do. So if you've got really mild de Quervain's, then you might be absolutely fine with an off-the-shelf splint and just have that little bit of a reminder, a little bit of restriction. But anything more severe than that, you're going to struggle unless you have something more restrictive.